Hello, hello.
Miss Jessica.
Hello.
Hi. If my camera goes in and out today, I just want to give you a heads up. I threw it on the ground by accident this weekend. So if there are any issues, I just want to give you a heads up. Well, I was cleaning off the shelf it was on. It was just blue.
So we cannot talk about the exam in class because there is someone that still needs to take it. So we must refrain from that, okay? Did I do somebody?
No.
Come on, big girl. There's 15, 16, 17, there's 16. I know, it's a lot.
That's all for today.
Today, what's today? Today's Tuesday?
Yeah.
Thursday? No, we only have like 2 hours today.
Yeah.
Yeah, can you repeat so I can hear you what chapters we're going over today so I can print them, please?
All right. Yes, ma'am. We're starting at chapter 8. I think it's like 8 through 18. And it's not just today. Some of them are really short. Like there's a whole chapter on deworming. Literally deworming humans. Like no. I don't want to talk about deworming humans. So like there's a couple chapters we'll just like fly through. And then we have to do GI. And I think GI is 60 through 62, maybe, I think, is GI. So yeah, like I said, the biggest chapters that we're gonna look at in these next couple days is going to be antibiotics, antivirals, GI. They're fine. They're fine.
I know. Do anybody got chapter 13?
Next Thursday.
Next Thursday.
Next Thursday.
She says
So we have class on Tuesday.
Yeah, let's do that. I want to do a review, which I think some people said that they have. There's a group that has a clinical on a Monday. So I'll probably do a review on Wednesday because nobody has clinical Wednesday, right?
Can you just report it?
I don't have clinical Wednesday, but I have work. So it just depends on what time you do the review.
Finals on Thursday. Finals on Thursday at what? 12? 12:30? 10:30?
Yeah.
Sorry, excuse my language.
I've heard birds chirping.
What about Monday night? Like Monday at like 7. Speak now or forever hold your peace. Monday at 7.
Monday.
Yes.
I
Everybody?
work Monday night, but if you record it, I can watch it.
Okay. Okay. And that way I won't be it won't be the night before and trying to get because apparently Ring Central hates me and takes 7 freaking hours to process it for video. That just really grinded my gears. Jamal, I see your message.
Miss Jessica, Maria Barker says she's going to be a little bit late. She has to get her kids to school.
Okay. All right. Yeah, so we're going to we're going to start on chapter 8. I also want to do a group review for exam 1 and 2, but I can't I cannot record. That is not allowed to be recorded. I would never want it to be recorded because these are my exams. So the exam review cannot be at the same time, like on Monday night, is what I'm saying.
Want to do Saturday morning?
Saturday morning,
No.
you volunteering me for a weekend?
Darn.
No, I'm just kidding.
Sometimes push it on. Or if you want to do Wednesday.
So the only thing would work for me, on a weekend would be during nap time, which is 12 to 3. So I would like to do like if we do a weekend, and I think my husband has something on Saturday.
I can't do weekends at all because I work during the weekends. So
Well, I cannot record
I mean,
the exam.
yeah.
Did the Monday at 3 o'clock work for people? I did. I was just sleeping. Because there was a clinical group that was done at like 2:30.
So what, are you saying so at 3 we do the
Like Monday at
review? And then
3 o'clock.
And then we do the,
Or do you guys have clinical on Monday? Niles C, do you guys have clinical Monday? Yes.
Yeah, we had clinicals yesterday, but we still did the review at 3.
No, I know. That's what I'm saying. On this coming Monday, next Monday.
we have
No,
clinicals this next coming Monday too. But if it's like after 3 o'clock, I could probably do it.
Well, that's what I'm saying. If we do the exam review at like 3, and we can do exam 1 and 2, let's review both exams on Monday at 3 o'clock. That cannot be recorded. Okay? So if anybody cannot make that and you need to meet with me individually, which by the way, if you do get a CPT or a SAP or whatever we are calling them these days, then you will have to meet with me individually.
what is the,
You don't need one.
oh,
That's just under 76. You would know if you got one. It's under 7. If you get less than a 76%, I'm not sure if I'm more concerned about the final or ATI. Yeah, amen. So we'll see. I'm more worried about the final because the final is worth 35% of your grade, and the ATI is only worth 10%, which is why I'm more worried about the final.
that's Monday at 3?
Quick question.
What? Yeah. Sorry, I didn't mean to say what like that.
A 1? That's okay. If we score a 1 on the HI Proctor, we fail the class no matter what our grade is.
Oh, girl, you cut
Is
out
that
like
correct?
that. Here, hold on. Hold on. I think I
Because
got
my
what you're
camera's on.
asking,
Can I
but-
turn it off?
Yes, yeah. Okay, so if you score, no, you will not fail the class because of a proctor score. If the proctor score drops you less than a 76, then yes, you will fail the class. So if you get below than a level 1, you will get a 55 out of 100, basically a 55%. Okay. If you get a level 1, you get a 70. If you get a level 2, which is the goal, a level 2 is the goal for all ATI proctors, you get an 85. And if you score a level 3, which is like really good, I believe I have all the numbers in my office for like what you need for each level. I can get that after we go on break. Somebody remind me. So if you get a level 3, it would be 100 out of 100. So the goal is a level 2. And the the only way that like a level 1 is definitely going to hurt you a little bit because 70% and it's 10% of your grade, that would hurt your grade. And then the 55 out of 100 would significantly damage your grade. Okay.
How much will it drop your grade percentage wise?
I don't know the lowest. I don't. I think it's different for every person. What you got on your exams, what you know.
Yeah.
I mean it's worth 10% of your grade. So correct. I mean if you got a 55% and it's worth 10% of your grade. My brain's not braining enough for that.
Yeah. No.
Right now.
Whatever.
I love math, but my brain is not ready for math right now. I'm gonna give ChatGPT. Yeah, there you go, Tony. She said I'm gonna give it to Chat. I agree. Do you go back? This is something that grinds my gears so bad. It makes me so mad. ATI is so butthurt about their exams, like their actual proctored exams. It is the only thing that they will not share with instructors is their actual proctored exams because of test integrity. And it's very annoying. They do give us an outline, but it's very generic. Let me pull it up. Very generic.
I'll take generic.
Over nothing. I agree. So just to be clear, Monday we are not scheduled for anything. I think one Niles group has a clinical, but other than that, I don't think anybody has anything scheduled for the 23rd on Ring Central at 3:00. 3:00.
Just 3, not 7.
3:00, we're doing our exam review. 7 p.m. is going to be the study tutor final section.
Are you going to email put reminders on my phone?
Yeah, I'll do that. Let me make a note of it. Monday exam review 3 p.m. Monday final review 7 p.m. Okay. And the final review for 7 p.m. I will post it. That is not an excuse for everybody to just like not come, because I'm going to tell you, you're going to make me real upset. If I'm literally sitting there and I have 51 students and I'm sitting there with 3 people live, I will be so mad. Okay, so if I wanted to do it by myself, I would do it by myself. Okay. Am I going to post it? Yes. Do I need and want you guys to do this with me? Yes. This is your education, not mine.
Monday
Okay.
don't work for me at all, so I'm watching the video.
Girl, that's fine. But what about the exam review?
Girl, I work.
Well, why don't you stay after class with Candace? Can you do that today? Yes? Is that okay? All right. So Monday we have that, and then Tuesday we have lecture. And then the ATI exam is after that from 12:30 to 2:30. Wednesday we have nothing. And then Thursday we have the final from 10:30 to 12:30.
Heather calling from SSR. We have an important message. If you
Please do share the Oreo with big high yield study packet. Oh, that's nice. Tony said, please do share the review. I will make a big, in capital letters, high yield study packet and email in the class chain. Tony, that sounds so wonderful, and I'm sure your fellow students will be very grateful.
What a queen.
What a queen. I love that. Queen. Okay, but you know what's so funny? I just took this piece of paper out and it says queen right at the top. That's weird. COPD clean.
Yeah,
Steven,
we're not talking.
Did you see the paper?
Yes. Yeah, I gave it to the person that needed it.
Awesome.
She definitely wasn't planning on anybody seeing that.
Felt like it was personal.
It was.
I did not read it.
I didn't know. I mean, hey, I handed it to her and I said,
Wow. Why did I stop doing that? Because I'm so nosy and I just want to know.
you're like, I don't know what it is.
Listen, I have nothing to do and I had it in my hands, and I was like, I probably should not read this. So I took everything in me not to read it. Yes. It's a letter for some things.
It was
I
a
don't know
letter.
exactly what, because like I said, I didn't read it.
It was a letter of recommendation.
Oh, there you go. It took everything.
But that doesn't mean that anybody knows what it's who it's
Right.
for.
Okay.
You know?
Yeah.
Or
I
what
was
it's
just
like.
Where did you find it? Found it? It was in the.
This is so here. She's like, I
Oh, we're
need
still here.
wait a minute. The details. My computer
Exactly
wants to
what time?
restart. Just go ahead and restart.
Oh.
I really truly apologize for doing the review yesterday so late. I mean, I did not in a million years think that it was going to take as long as it did for that video to process. I mean, obviously there's nothing I can do about it. It is what it is. But I do feel bad about that. So, all right, are we ready? Let's get going. Okay.
And they just gave all the facts and understood it. I said, no. Oh, you don't change it. You move on. Someone called her. So I thought about it. It's actually, and I said, I'm going to the business. I said, if they have 6 persons working in this, people. This is restricted by.
Okay, ready? Okay, antibiotics. Chapter 8. So this is really just talking about where they came from, how they work. So in the 1920s, some Paul dude worked on developing a synthetic chemical that was effective only against infection-causing cells. And in doing so, Paul saved a lot of lives, like a lot, okay? Scientists discovered penicillin in a mold sample with oranges, if you didn't know. Mold that grew on oranges is how we found penicillin. In 1935, we found sulfonamides. So the thing about antibiotics is that most of your antibiotics were found in nature, okay? And then chemically engineered to be used to help us fight infection. So when we talk about antibiotic resistance, which is the most important aspect of the use of antibiotics, especially now in 2026, when we talk about infectious disease, we can't just like go get new ones. Okay. Can we bioengineer some new antibiotics? Sure, but it's not easy. This is not something that is simple in any way, shape, or form, which is why we haven't had a new antibiotic in a very, very long time. Okay. And if we do or have had one, it is most likely a combination with something natural and chemically engineered or completely chemically engineered. Okay, which kind of freaks me out. So anyways, since these early developments, there's a number of anti-infectives. So we've found a lot more antibiotics. Okay. Unfortunately, organisms are extremely smart, whether we're talking about bacteria or viruses, and they adapt and they become resistant, which is what we call bacteria resistant, bacterial resistant antibiotics. I feel like I'm flipping those words around, but bacteria that are resistant to antibiotics, okay? Multi-drug resistant organisms. There it is. Multi-drug resistant organisms. That's the word. There's no anti-infective agency. No anti-infective agent possesses total selective toxicity, which means it is not going to just completely destroy. Antibiotics work with our bodies to fight off infection. Okay. What are these words? Just like makes sense.
Well, I kind of read it like it doesn't. Antibiotics don't just kill they don't select just the bad bacteria. They kill like all. That's kind of.
They kill all bacteria,
Yeah.
good or bad.
Yeah.
And we all know that, especially women that have vaginas. Okay. Because when you kill the good bacteria, that's when you get yeast infections.
Yeah.
Yay for us. Okay. Children, obviously, with all children, we want to use caution. And we don't want to expose our kids to all the antibiotics as soon as they're born. Okay. There are some kids that have immune systems like a brick wall, and they're blessed. My poor child, my poor sweet Henry, that first year, which was his second year of life, but that first year in daycare, oh, we were sick. I'm not kidding, twice a month.
Mm-hmm.
It was horrible. Guess who hasn't been sick?
Yeah.
In a minute. You and him, me and him. And I'm knocking on wood. Okay? Because I really don't want to get sick. Adults often are quick to be like, I need antibiotics. I need antibiotics. I have a sinus infection. I need antibiotics. I need antibiotics for everything. Well, guess what? You can't treat a virus with antibiotics. And people don't like to hear that. They don't like to hear that they're sick and nobody can give them anything, which is another thing that led to multi-drug resistant organisms. Okay. Of course, we want to be cautious with patients that are pregnant or lactating. Us ladies that have 4 children know that. It's miserable, which is why Afrin is the most beautiful thing in the world. There was a video that just came across my TikTok about Afrin addiction. I was like, big brother, you need to stop listening to me because that's rude. Older adults, of course, we know that there are changes that happen as we age, including the way that our kidneys function, the way that our liver metabolizes. Drugs stay in our systems longer. There is something called the Beers criteria, BEERS, Beers criteria. This is a list of drugs that are nephrotoxic, hepatotoxic, and specifically drugs that need a lower dosage for the elderly population. Okay. If you haven't seen it, you should look it up. You should have at least seen it by now. But the last time I said that, my students looked at me like a deer in headlights and said, I've never heard that word in my life. So look up the Beers criteria, okay? It is not tested. I just need you to know that this is something that it exists and it's extremely important for dosing in elderly people, okay? And
So
older people.
what did you say it is again?
The Beers criteria?
No, like, can you please spell it?
B as in boy,
Yeah.
E as an elephant, E as an elephant, R as in Roger, and S
Okay.
as in it's an acronym.
Okay.
I don't know what the acronym stands for. I don't remember.
Okay. Thank you.
Geriatric Society. Well, that's the Beers criteria. Oh, okay.
Yeah, it was made by the American Geriatric Society. Yeah. So therapeutic actions of antibiotics, they interfere with the biosynthesis of the pathogen cell wall. Pathogen, that's the bad guy. Okay, pathogen is a disease. It is something that causes disease. The biosynthesis, how it's made. So if it interferes with the way that it's made, then it cannot survive very well. Because the cell wall is the only thing that protects it. It's like their skin, their skeleton. If you disrupt the way that it's made and make it less strong or weaker, then it's going to be more easily killable. They can also prevent the cells of the invading organism from using substances essential to their growth and development. So we need a lot of things for our growth and development. We need glucose, we need vitamins, we need amino acids, we need all these things, right? So if we take something that causes our cells to not accept amino acids, oh my God, we'd be screwed. We would be so screwed. And we would probably die because we need amino acids to survive. Okay. Interfere with steps involved in protein synthesis. Amino acids. How about that? Interfere with the DNA synthesis. The DNA is obviously the blueprint of the cell and all of its things that it does. So if you disrupt the DNA synthesis, then you're probably going to disrupt its reproduction. Okay. And then alter the permeability of the cell membrane to allow essential cellular components to leak out. So that pretty much means that the inside of the cell is just like leaking out of the cell wall. So it can't hold its contents. Okay? Making it very weak. All of these is a way for an antibiotic to destroy a bacteria.
But bacteria can't. Or like itself.
No, you're fine. That's one of them. Is that it can affect the reproduction of the cell.
The bacteria.
The antibiotic affects the way that the cell reproduces. The bacterial cell.
Okay.
So I'm a bacteria. I take some amoxicillin, and I'm just spouting this from my brain. This is not real life. Please do not write this down. This is not scientifically based. I'm just using it as an example. Amoxicillin possibly, maybe, because I don't remember, alters the way that I reproduce. So that when I want to reproduce, it doesn't work. So then when I die, I don't have anybody to take my place. So my infection dies. The bacteria dies with me.
Okay, so
does that make sense?
Yeah, so the cell doesn't keep reproducing.
It can't. If the DNA, but you have to understand that not all antibiotics work that way. They work in multiple ways. Okay, that's only one of the ways that it works.
Oh, wait.
Anti-infective activity. So the activity varies in effectiveness against the invading organisms. We have narrow spectrum or broad spectrum. I'm sure we've all heard the word broad spectrum antibiotics. Okay. A good real life example of this would be Zosyn. We give Zosyn to everybody and their mother. because it's a broad spectrum antibiotic, which means it can affect cell or bacterial cells on a broader spectrum. Okay. So narrow spectrum, is that a Z-Pak? A Z-Pak is azithromycin?
Yeah.
Azithromycin. I don't remember if azithromycin is a broad spectrum antibiotic, then yes. Just don't remember if it is. I agree. I feel like it is too, but I don't want to give you wrong information.
Yeah.
So, and yes, it is. Okay. Narrow spectrum is effective only for a few microorganisms. It's very specific. Okay. And then broad spectrum, it reacts to many types. So we have bacterial or fungicidal or bactericidal or fungicidal. It resembles a certain word. No, cidal. It's like cidal.
Yeah, like that.
Right? So bactericidal or fungicidal, the word cidal means die, death. Okay. So this is cell death. We're causing the death of the organism. Okay. Bactericidal. Somebody said spermicidal. It's when we kill the sperm, right? Think of it the same way. Bacteriostatic or fungostatic, this prevents or slows the cell's reproduction. Replication, reproduction, replication, same thing. Okay. You should know the difference between bactericidal and bacteriostatic. Okay. The human immune response, the goal of anti-infective therapy is reduction of the population of the invading organism. Of course, we want to we want to get rid of our infection, right? That's the whole point. So if we can eliminate it on our own by our inflammatory response, our immune response, having a fever, XYZ, we can fight this on our own. Great, wonderful. You are probably fighting bacteria in your own body right this very second. Okay? When we get sick is when our body's immune system fails. And we need those antibiotics to help us fight that infection. Okay? So we could be fighting 100 different bacteria right this very second. Okay? Drugs that would eliminate all traces of any invading pathogen might be toxic to the host. We are the host, the human. I am the host to the bacteria. I don't want to take drugs that kill me. No, I don't. This is where we have a very fine line when we talk about chemotherapy agents, right? Where when we put drugs in our body that are so to kill us in order to kill the invading organism. Okay, very scary stuff. The immune response involves complex interactions among the chemical mediators, leukocytes, lymphocytes, antibodies, and locally released enzymes and chemicals. We have an entire inflammatory cascade that occurs, an immune cascade that occurs. Leukocytes are your white blood cells. Lymphocytes, as in your B cells and your T cells.
Okay, so in the history of SpongeBob, there have been only one episode of SpongeBob.
So your B cells and your T cells are the ones that recognize an invading antigen and then say, hey, I have an antibody for that. Or, oh, I need to make an antibody for that. Okay. Anti-infective drugs are not effective on all pathogens that cause illness. And this is where we talk about how antibiotics don't work against viruses. Antibiotics don't work against fungus. Antifungals work against fungus. Antifungals don't work against bacteria, right? Okay. So our prevention especially in a healthcare facility. So number one is always going to be hand washing. Removing invasive catheters as soon as possible. This includes our Foley catheters, our central lines. Okay, every hospital in the US, probably the world, I don't even know, but they have CAUTI and CLABSI protocol. CAUTI, catheter associated urinary tract infections. CLABSI, central line associated blood infections. And we need to decrease those as much as possible. Keeping immunizations up to date is extremely important. Following transmission-based precautions. So this is your PPE. Okay. Resistance, antibiotic resistance. It is a scary, terrible thing, and it's happening every day, and it's not fun. It's scary. Ability over time to adapt to an anti-infective drug and produce cells that are no longer affected by a particular drug. Okay. When hospitals get infected by what we call a super bug, there was a Netflix documentary, I feel like it was like 10 years ago. They had a Klebsiella breakout in a hospital, and they couldn't figure out, it was I believe it was in an ICU, and these patients were dying of Klebsiella. And it was resistant to everything. They could not find an antibiotic that this bacteria was not resistant to. And the CDC had to come in, like the big dudes in suits and hazmat suits, coming in and doing a full-on investigation. And I believe they actually sourced it to not only hand washing, but also, I think, the rails on the walls, I think, is where they sourced it to. Not 100%. It was a long time ago. And this is why it's so important that we don't keep encouraging resistance with our antibiotics. So we have natural resistance and acquired resistance. Anti-infectives act on specific enzyme systems or biological processes. And then you have microorganisms that do not use that system or process. So it's natural that not all bacteria are going to be susceptible to the same antibiotic. That's just how it works. Okay. But then acquired is where we get ourselves in trouble. That microorganisms that were once sensitive to the drugs that we gave, and now they look at it and laugh and say, what do you think you're going to do? Because I'm not affected by you. Okay. Acquiring resistance occurs from producing an enzyme that deactivates the drug, changing the cellular permeability to prevent the drug from entering the cell. They're very smart. Bacteria and viruses are extremely smart. Alter the binding sites on the membranes or the ribosomes, which no longer accept the drug. So they just, you're not getting in here. I don't have anything that's going to let you open my door. No way. Produce a chemical that acts as an antagonist to the drug. Okay, so just like turns the drug off. What is a major consideration when treating infection in a person who is immune compromised?
A.
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 A. The lack of immune response to deal with even a few invading organisms. So a significant consideration is that the person may lack the immune response to deal with even a few invading organisms. Remember, I told you, the bacteria and our immune system work together to kill the infection. If we have no immune system, the antibacterials can only do so much, okay? So while proper nutrition is important, it's not critical it's not as critical a concern as the effects of the person's immune compromised state on their ability to fight infection. Exercise is also supportive of a healthy immune system, but may not be recommended for the immune compromised patient. While it may be difficult to treat such patients because anti-infective drugs may be unable to completely eliminate the pathogen without causing severe toxicity and then damaging the host. Okay. So the goal is to prevent resistance. So we limit the use of antimicrobial agents and only use them to treat the very specific bacteria that they are capable of treating. Make sure the doses are high enough and the duration of drug therapy is long enough. Remember when we were talking, I think it was like week 1, we were talking about how macrobid was like a really big drug to treat UTIs, and it was like for 3 days, and it worked for many years, and then all of a sudden it just stopped working because the bacteria got smart and it became resistant to the macrobid. So no longer were you able to take an antibiotic for 3 days. Now you're taking a different antibiotic for 7 to 10 days. Twice a day, 3 times a day. Okay. And it's because the bacteria adapted. So if the dose or the frequency is not high enough, we contribute to resistance. Okay. Always advise patients to take the entire course of the drug. If you want to piss off a nurse real fast, tell them you're not going to take all your antibiotics, because that's really going to make us mad.
So that's what contributes to the resistant, the MLC resistant drugs is not finishing.
When you don't finish your antibiotics, it gives the bacteria the capability of learning and changing and then passing on what they've learned to the bacteria that they reproduce. Okay? It's just like us having a baby and then teaching our child the things that we were taught instead of letting them figure it out on their own. So after generation and generation and a generation, these things are passed down and learned and changed and adapted so that we're not struggling like our great-great-great-great-great-grandparents in the 1800s, right? And the more ability that they have to survive, the more they're able to pass on this information. Okay. And then be cautious about the indiscriminate use of anti-infectives. That means don't use an antibiotic for a virus just because you feel like it, because it's going to make you feel better in your head. Oh, well, I'm taking an antibiotic for a viral sinus infection. Okay, good for you. It's not doing anything except helping antibiotics become more resistant. Okay. Treatment of systemic infections. Systemic means the whole thing, the whole body. Okay. Local means one part, one little teeny part. It's localized. Okay. So systemic, treating in systemic infections, the identification of the bacteria is done by a culture. In order to figure out when or what antibiotic is going to be good enough, you have to do what's called a C and S. C and S, a culture and sensitivity. Okay, the culture identifies the bacteria. The sensitivity identifies which bacteria or which antibiotic kills that bacteria. Okay.
And that's adjusted per person. Like that's because it's not the same for every person.
It's not about the person, it's about the bacteria. So if I have a UTI, I pee in a cup, I send my pee to the lab does a culture and it says, you're positive for E. coli. Okay. That doesn't mean that any drug is going to kill E. coli. So then they have to do a sensitivity to figure out which antibiotic that specific bacteria is the most sensitive to. Okay, so that we can treat it appropriately. We have combination therapy. So in infections caused by more than one organism, each pathogen can react to a different anti-infective. So when you, Zosyn is a combination. It's two antibiotics together. So when you combine two antibiotics together, they work in combination with each other to fight the infection. Sometimes the combined effects of the different drugs delay the emergence of resistant strains, which means it kind of helps prevent the bacteria from learning so quickly.
So augment will be.
Yeah, because it's amoxicillin and the one that starts with a C, clava, blah, 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 blah. Yeah. So yes, augmentin is a combination therapy. Prophylaxis. Prophylaxis is just another word that means prevention. Okay. So what do we do to prophylactically or prevent things from happening? So people traveling to an area where malaria is endemic, we vaccinate. Okay, we have anti-malarial drugs. Patients who are undergoing GI or genitourinary surgery, I'm going to say this, and I want you to remember it. The only time that we ever give prophylactic antibiotics is in very specific situations. And that includes surgical procedures and is dependent on the physician, by the way, and is very closely monitored by the CDC. I never knew that until I worked in the OR. People that have cardiac disease, endocarditis, they have a valve replacement, they have to take antibiotics before they go to the dentist. Okay? These are prophylaxis, yeah. And if they have other conditions that require invasive procedures. So like the dentist. So if I have a cardiac disease, or I have endocarditis, or I have had a valve transplant, then, and I have to go get a filling done or a tooth pulled, I'm going to have to take my antibiotics, which I already have because they teach me I need to take this before I go do any of these things. I'm going to take that before I go to the dentist. And then the dentist is going to say, did you take your antibiotic? And I'm going to say, yes, sir. Yes, ma'am. Okay. So these are the only reasons why we take prophylactic antibiotics.
So basically everybody that wants to get that diagnosis. Huh? So it's like, it's not, you know, it's not intense. So the drug prophylactic just means preventive.
Yes.
So you can take it.
Prophylaxis is not a drug. Prophylaxis means prevention.
So, okay, so then that just means that everybody takes it though, right? It's not like for specific.
No, this is only in very specific situations that were on the last slide.
Well, I'm saying like, so if anybody that's going to get surgery takes that, right?
No.
Anybody that
I'm saying
has this condition.
I'm saying that I'm going into surgery and I'm having my knee replaced. Okay? And my surgeon wants to decrease the risk of infection. So they say, I want you to give 1 gram of ceftriaxone prophylactically before we start, before incision. That is a prophylactic treatment. Okay? It is dependent on the disease It's dependent on the procedure. So I'm saying if you had a valve replacement, you would need to have prophylactic antibiotics. Okay. If you were going in for any type of surgery, and like I said, this is up to the surgeon, not up to anybody else but the surgeon, and it's tracked by the CDC. And they say, I want to give a prophylactic dose of antibiotics. So no, it's not for everybody. It's for only the people that fit that criteria, or if it has to do with surgery, it's up to the surgeon. Okay. Adverse reactions to antibiotics. Kidney damage, which we call nephrotoxic. Okay. Nephrotoxicity. GI toxicity. Neurotoxicity. Hypersensitivity, which is anaphylaxis or allergies. And then super infections, which are bad news bears. Very bad, 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 bad. Super infections are very difficult to treat. And then when you get the CDC involved, they're no fun. They're like the guys in Monsters, Inc.
Does it affect the liver too?
Yes, hepatotoxic. Hepatotoxic should be up there. So you're caring for a patient who has just been diagnosed with Pseudomonas, which is a type of bacteria. You know that in deciding what anti-infective medication to order for this patient, the physician will take what into account? So is Pseudomonas a fungus? No, I just told you it was a bacteria. Does the half-life, is that something that's like super, I mean, is it important? Yeah. But it's more important when we're talking about the frequency of the dose. Like, you know, when you have to take Keflex 4 times a day and you're like, are you so for real right now? You want me to take this big ass pill 4 times a day? It's because of the short half-life of the drug, right? You take it 1 time a day. That means it has a longer half-life. It covers you for that whole 24 hours. If you take it 4 times a day, that means that pill is only covering you for 4 to 6 hours, and you gotta take more of it to cover the whole day, right? Yeah. I was so mad. I had a little tiny pimple on my arm, and obviously I had to pick it. Obviously. It was a little whitehead. Okay. So I popped the little bugger. Next morning I wake up, guess who has cellulitis? Mm-hmm. Are you so for real? Like, I am a healthy 34-year-old woman, and I picked a little teeny tiny thing, and boom, I have cellulitis the next morning. I had to go to the urgent care. And he's like, I'm going to give you Keflex 4 times a day. I'm like, dude, for real? For real? So, anyways. The drug that causes the fewest complications. Love that. Right? I love that. And then the drug that interferes with biosynthesis. This is the way that the bacteria is made. So is it B or C? It is C. Because we don't want to kill the host. I don't want to hurt the host. I have to take in the considerations of how the host kidneys work. And how the liver metabolizes. Okay. So the provider will consider the drug that causes the fewest complications. And antifungal, obviously, this is not a fungus. Okay. Interfering with biosynthesis is only one of the ways that an antibiotic works. There was like 5 of them. Okay.
That's about the big leagues.
And the half-life is not relevant to the selection. Because if you need more dosage, you're just going to get more dosage. It all depends on, number 1, keeping the host alive, and number 2, the sensitivity.
I could be thinking about something else, but did you say something about once you get cellulitis once?
I wasn't talking about cellulitis,
You talking about something.
but I was talking about something with her. Yeah. Absolutely. Once you DVTs. Yeah, once you get a DVT or any type of clot, you're going to be at a higher risk, like a 50% higher risk. Fun fact, I just started back on birth control because I feel like I'm going crazy when I start my period. Like it just seems so irrationally insane in my brain. And I hate it. So on the package, I'm like reading the package. And it says that if you're over the age of 35 and smoke, then you're not allowed to take this. And it's because it massively increases your risk. I'm 34 and I don't smoke. Quit smoking a while ago. So, chapter 9. Antibiotics are chemicals that inhibit specific bacteria. We already kind of talked about this. This is one thing that I like these slides, but I also hate these slides because they're very repetitive. But it might be helpful to you to have that repetitiveness. So they're made in 3 ways. By living microorganisms, which we already talked about, by synthetic manufacture, so man-made, and in some cases, genetic engineering, which is scary. Like biogenetic engineering, it's like making something out of nothing or like changing the DNA, and like it just freaks me out. Like freaks me out because they can change the bioengineering of a bacterial cell, then they can absolutely change the bioengineering of my cells. Scary. So again, bacteriostatic versus bactericidal. Bacteriostatic inhibits the growth of bacteria. Bactericidal kills. Signs of infection. You should already know this. Fever. Lethargy, which is fatigue. I'm tired. I don't want to do anything. I'm in my bed. Elevated white blood cell count. And then classic signs of inflammation: redness, swelling, heat, pain. Okay. We already talked about the goal of antibiotic therapy is to decrease the invading bacteria. We talked about culture and sensitivity. The one thing that I do want to talk about culture and sensitivity. If a patient comes in and they need antibiotics, what do you do first? The culture or the antibiotic? Culture.
Sometimes, yeah, they'll start them on the broad
What is
spectrum.
the correct culture first? The NCLEX way, and really the way of it should be. It shouldn't be about convenience. It shouldn't be about whatever. The way that it has to be, especially if you want to not aid the resistance in bacterial growth, then you as a nurse need to make sure that you get that culture before you start antibiotics. Okay? You need to make sure as a nurse, it is on you and your license and how you sleep at night to be able to say, I got my blood culture before I started my antibiotic. I got the blood culture, or I got the urine culture before I started the antibiotic. Now, am I saying that I want you to wait 10 hours to give vancomycin to someone who is dying of pneumonia because you can't get a sputum culture? Hell no. Absolutely not. That's ridiculous. But if you have to wait 5 minutes, or you have to straight cath somebody real quick, or you just have to go and run to another unit to get a swab and you're just trying to be lazy instead of getting that culture before you start the antibiotic, that's on you. Okay? Because that antibiotic is going to change the way that your culture and sensitivity is going to come back. So, in real life and on NCLEX, the way that it should be done is that a culture and sensitivity is done first before an antibiotic is started.
How is the antibiotic even prescribed if the culture is not done first?
Because that's why we have broad spectrum antibiotics. Because here's the thing. Even though our culture is going to take a couple hours, our sensitivity could take a day or two, right? So what do we do in the meantime? Not treat anybody? No, of course not. We have to treat them with something, which is why we use broad spectrum antibiotics until our sensitivity comes back and we can say, okay, this antibiotic or this bacteria is gram-negative, rods, streptococcal, blah, blah, blah. And I need to treat it with blah, blah, blah. Okay? So there's classification of bacteria. There's gram-positive, which means if you go back into like microbiology, high school science, where you have the little, what are they called? No, the slides, the little slides. And then you put the dye on it and it turns purple, right? And you can see it under the microscope. Never? You never did that?
Yeah.
Girl. What do they do in Florida?
Nothing.
It's a crazy place.
They don't learn.
When I tell you, I learned nothing new.
Florida
Seventh grade
is a crazy place. Okay, so gram-positive is when the cell wall retains that stain. You should look up a picture.
Yeah, I literally did before.
So it retains the stain or resists decolorization with alcohol. So that means it holds on to that color. Gram-negative is the cell wall loses a stain or is decolorized by the alcohol. So it's not purple under the microscope. Okay.
So question, why does it turn pink?
It's something within the cell wall.
Oh, okay.
It's I don't know if it's like a protein or what it is, but it's something within the cell wall that either holds it or doesn't. And then that distinguishes whether it's positive or negative.
And aren't one of those way worse than the other?
I don't know. She's asked me too many questions. No, I'm just kidding. I'm just kidding.
That's too sciencey.
Aerobic depends on oxygen for survival. Anaerobic, we don't need oxygen. Okay. So if you've ever seen someone take blood cultures or you have taken blood cultures yourself, I don't know if LPNs can take blood cultures. No?
You can, but they don't utilize it.
It's probably not within your scope. That's what it is.
I take them in dialysis as a dialysis.
So you have to be trained to do it then. So it's within your scope if you're trained
When
to
I was a tech in the ED, I could do it.
Right. And some do. Like if you're an older nurse, yes, they don't have that license. Whereas in the toilet mask, put that license on stuff. Can't be like, I can't do that in my thing. It's what is happening.
So my point is that a blood culture has two bottles. Okay. One bottle is aerobic, one bottle is anaerobic. Okay. And they're like that for a reason, because one grows with oxygen and one grows without it. So if you only have one culture, you're completely forgetting the other half of bacteria that does or does not need oxygen for growth. Okay. We already talked about bacteria and resistance. Our first drug classification we're going to look at is called aminoglycosides. If you notice, they all end in -icin. And this is a group of antibiotics that are used to treat serious infections that are primarily caused by aerobic, so they like oxygen, and they're gram-negative, so their cell wall does not hold the stain, bacilli. That's just the way that they're shaped. So,
know that part?
The shape? No.
The aerobic gram-negative part.
Well, I think what I care more about is if you know if it's either broad or narrow.
Gotcha. You said it's aerobic or anaerobic?
It's aerobic.
Aerobic.
So your most common medications on this list are going to be gentamicin, streptomycin, and tobramycin.
Can you name those again? I'm so sorry.
Gentamicin, streptomycin, and tobramycin. So these drugs are bactericidal, so they cause the death of the invading organism. And the way that they do that is they inhibit the protein synthesis. So that means it can't synthesize proteins to survive. Cells must have proteins. Our cell walls are made of proteins. Go ahead.
And you said we should know the term, not
The generic name.
Got it.
Yes.
I just want to make sure.
Yeah.
That's the one that ends in IC.
Yeah. And they also irreversibly bind to the unit of the bacteria ribosomes, leading to the misreading of the genetic code in cell. It's also not letting it reproduce. So pharmacokinetics, this is how it gets absorbed in the body. Okay. So these are poorly absorbed from the GI tract, but rapidly absorbed after IM injection. So that means that these drugs aren't normally given PM. They're not given oral. Tobramycin specifically is usually an eye drop, an ointment, or an ear drop. Okay. They are widely distributed throughout the body. They cross the placenta and enter human milk. And they are excreted unchanged in the urine. When you see that, I want you to automatically think nephrotoxic. All of these are contraindicated with a known allergy. I really don't want to say allergy 700 times today and on Thursday. So can we please assume that everything is contraindicated from an allergy? Okay. Renal disease, pre-existing hearing loss. That's very important. Myasthenia gravis, Parkinsonism. That means you're having signs of Parkinson's without having Parkinson's. Use caution during pregnancy. And we need to lower the dose for patients who have renal impairment. So it's not necessarily completely contraindicated when you have kidney disease. It has to be very cautious. There's a risk for nephrotoxicity and oto ear, which is why you wouldn't want to give this to someone that have pre-existing hearing loss.
Lord. I'm starting to see that proctored exams talks about the stuff that we ain't covered yet.
Because it's for the whole class.
Yeah, somebody could tell me that shit.
What do you mean?
Just I thinking about that test. I just
God.
saw all this on the exam and I was confused on what they because I didn't catch it.
So if you look on page 106 in your Karch book, The textbook, your textbook. It says streptomycin has been associated with deafness in newborns when administered to people who are pregnant. Seems like a big deal. Yeah. Seems like a really big deal. Okay.
Can you repeat that?
Streptomycin has been associated with deafness in newborns when administered to people who are pregnant. That is on page 106. It is necessary to test renal function and drug levels frequently and use lower doses with patients that have renal impairment. They depend on the kidney for excretion and are toxic to the kidneys. The potential for nephrotoxicity and ototoxicity with aminoglycosides is high. So these drugs are used for resistant infections and only for as long as necessary. Streptomycin specifically is only used in special situations because it is very toxic to the 8th cranial nerve and kidney. It can be used in severe infections if the organism has been shown to be sensitive to streptomycin, and no less toxic drugs can be used. The book says very important things.
Is this the nursing considerations?
Oh, this is on page 106 in your Karch book.
Oh my God.
Me too.
So for the ototoxicity, that once the damage is done, it's just done. It doesn't.
Once you lose hearing, you don't get it back. Yeah, that's a good question.
So basically, there's already hearing loss isn't hearing losing. The hearing loss isn't deafness, it's just a little box.
If you have pre-existing hearing loss, they don't want to make it worse and then make you completely deaf.
Okay.
So that's why it should be caution or contraindicated with people that have. So your adverse effects are serious and limit usefulness, which is basically what I just said on page 106. The CNS effects, this affects, like I said, your 8th cranial nerve, which affects your hearing. Renal toxicity, GI effects, cardiac effects, which include cardiac effects can include palpitations, hypotension, and hypertension. Basically, all antibiotics are going to cause nausea, vomiting, diarrhea. You're going to see it in basically every single antibiotic. Okay. And little tidbit, most antibiotics you should take with food. There are very specific antibiotics that you take on an empty stomach, which I will tell you. Not right this second when we get to them. Okay.
What were the cardiac effects that you said? You said hyper?
Palpitations, hypotension, and hypertension.
And they say to take, excuse me, to take them with food to help relieve the GI upset symptoms, correct?
Aminoglycosides are not oral. Remember, they are not, they do not get properly absorbed from the GI tract. So they're not PO. These are IV, IM, eye drops, ointments, ear drops.
Everything but the stuff.
Basically everything but in your mouth. Another thing on page 106 under adverse effects says bone marrow depression may result from direct drug effects on the rapidly dividing cells in the bone marrow. So this can also affect your immune system. These are very serious antibiotics. Okay. You do not I almost said something wrong. Synergistic, which means they work together. Bactericidal effect with penicillin and cephalosporins. By the way, penicillins and cephalosporins are cousins. We're gonna get to them eventually, but just put that in your filing cabinet. Penicillins and cephalosporins, they're related. They're cousins by blood. Okay. So if they're bactericidal together, that means they can be used together therapeutically if necessary. If these drugs are already nephrotoxic, I don't want to use them with other drugs that are nephrotoxic. No, I don't. Increased neuromuscular blockers. That includes a drug called succinylcholine, which is a paralytic. I'm not going to test you on that. I just wanted you to know what it meant. We give paralytics for surgery. We give paralytics sometimes in the ICU when patients are intubated and they need to breathe better. We'll talk about that in critical care. But if something increases that neuromuscular blockage and that paralysis, we need to know, because if our patient's paralyzed, that means they can't breathe. And if you can't breathe, then you die. Okay. So at being able to important, and if it's increased, we need to know that. Okay. Let's take a break. Okay. Is it 2 or 2:30 today? 2:30?
2:30, yeah.
Let's take 15. Okay. And I'm going to restart my computer because it keeps yelling at me.
Kayla, your mic's on.
Your mic's open.
Forever. That was it. I'm still actually starting. I like it. They said, are you interested in tomorrow? Next month, work my 6 months. When they go 8:15. You got to learn because we got to stress about next month. Maybe like 8. What class is that? It's an OB. Well, that's a little more. I know a little more about the no.
Okay, sure.
No.
No. All right.
I just gotta remember something. I was like,
I didn't think of it from so good.
Okay.
And it is. But maybe I thought advanced farm would be more medication that I don't know, but it's not. It's more body systems and it's all medication system.
But I do that on purpose. Lack of AMP.
You're not lying because I can tell you now. Now, for real, when I go to work and look at medication, I'm like,
You look at them differently.
Stay with the hell this thing. Literally, yeah.
That is the difference with the way that I teach. Because I need you, yes, I want you to pass tests. Yes, I want you to be successful in nursing school. I need you to be a safe nurse. And if I can even give you little things that you can remember, that you can look back and be like, oh, I remember her saying that. Like I literally still remember moments of school and I can see my teacher standing in front of me and I remember we were in pharmacology and she was talking about stimulants and her name was Mrs. Burns and she was so funny. She was a big lady. She was so funny. And I remember her talking about how stimulants, at first they stimulate the GI tract, but then they like shut things down a little bit because it's like go, go, go. And she's like, don't you ever notice when you sit down, you smoke a cigarette and then you gotta poop?
oh, she's
And I just see her in my brain. Like, and I don't know.
Certain things people say.
Yeah.
It definitely just makes a difference. And I keep saying, like every time, of course, people are like, oh, school. I'm like, the
Pathophysiology.
Yes, I said that's all I can say.
It's so
really
important.
Get into the patho of things versus my LPN. So, like I said, when I do be at work and I be looking at stuff, I'm like,
You look at it differently.
yeah,
Yeah.
I can say. And like to my LPN, I might have been a little more hungrier. I was saying to get it. I don't feel the same with.
Because you have that knowledge behind it now, so you don't have to like work so hard to understand it.
okay.
Maybe you don't have much stuff.
We got time.
Bye.
I mean, after exam 1, I came back to talk to you guys. She got up, she walked right away. She said, I'm not talking to her. Straight up, she said, I'm leaving.
I don't believe in like defeat. I just believe
There's no defeat.
it might not be with the grade that I wanted, but if I would pass, probably it's gonna be something that will work. Okay.
People say that to me all the time. Like,
I guess we have 2
yeah,
more
but
minutes.
that's good enough for me.
Because that's good enough for me. That's strong.
So when I went to nursing school, I was really obsessed with my grades and I was really obsessed with getting A's and I was really obsessed with all the things. And then my school closed down 3 months before I was supposed to graduate.
Oh, okay.
Start over. And I had to start completely over. And I went to nursing school twice. No, of no fault of my own.
They did that to ITT Tech.
I went to ITT Tech.
Oh.
September 6th.
Yeah.
2016. September 6th, 2016 was the day I woke up and got the email from the Department of Education saying that they closed our school nationally. I was 3 months from graduating.
They didn't give you credits.
You can't transfer nursing credits. I was able to transfer my gen eds to YSU, which was really great, which is why I always say the RN to BSN program at YSU is like the best thing I ever did. Did they give you your money back? I was so scared to do anything with my loans that I waited until after I graduated with my BSN, because you can't take that away from me. Like, I graduated from a university. I have a university Bachelor of Science degree, and you cannot take that away. They accepted my credits. So I waited until after my BSN to apply for the loan forgiveness. And I did get, that school was $55,000, and I got 30,000 discharged from my student loans. So it was a silver lining for sure, for sure. But
So it's 50,000 to go from.
no. ITT Tech was $55,000. Okay. And I got.
It is a nurse I work with though. He had just finished, but still, he was in a lawsuit with them too.
Oh yeah, I still get money here and there. It's like $20.
Yeah,
like it's not a lot.
Go get Chick-fil-A here.
It's not a lot of money. But yeah, we're all in a lawsuit against them.
help him. That's why
So my point of saying all that was when I started working as an RN in June. I tested, I passed my NCLEX on June 5th. I literally transferred like the next week from St. E's Boardman to St. E's Maine as a nurse. And I started my BSN, my RN to BSN at Chamberlain online. And I believe I started in December because, you only have 6 months, right? Girl, it didn't work. First, it didn't work out for me. Okay. So you have 6 months until you have to start repaying your loans. And so I was like, 6 months is enough, right? No, it wasn't. I was so tired. I was so drained. I was working crazy hours. I was working days, nights, afternoons. It was a shit show. And I failed my first nursing class. And I was devastated. And I didn't go back to school for my BSN for at least a year and a half later. And I never even told I don't keep secrets from my husband often. And I did not tell my husband for years. I think I just told him like last year or something. Because like at this point, it doesn't matter, But at the time, oh my God, I was so distraught. Like I had never failed ever in my nursing career, like nursing school, nothing. I failed my first class. I was like, it humbles you for sure.
But why do you think it's so different from Ross or any other college too? Because I have to pay my LPN, no issues. But Ross, I have a hard time grasping it. I don't know what.
So I don't think it's the school. I think it's the way that it's. I mean, maybe it's the school. It's the way that it's given in such a short period of time. I mean, 4-week classes that's crazy. It's crazy. 4-week classes compared to like a normal 7 to 15 weeks. Like 4 weeks is just so fast. And I went to an accelerated program.
Only 2. I think.
And 4 weeks is really a lot. I mean, I worked full time during school, but I didn't have kids. I wasn't married. I was, like I had a car payment. Like, and I mean, yeah, we paid rent, but like we were kids, like, I mean, we were in our early 20s. My husband had already graduated from college. He was like making better, not great money, but like better money than me, and our finances were together. So like whatever I could put in the pot, I did, but like it would be like, it is so different now with working full time like I am now, because I never worked this hard in my life. And having a toddler, having a home to take care of, school on top of it, like it's just so much harder now with everything because we are the adults. Like everything depends on us. We have babies to feed. We have like bills to pay. Like we got food to put on the table. Like inflation is disgusting. All right.
To bring home the bake.
And when you don't have that fire, like right now, I don't feel a fire with school because of everything that I've been through in the last month, which is why I need to drop 2 of my classes. And when you don't feel that fire, it just feels like a burden.
Mm-hmm.
Yeah. And when it feels like a burden, you don't want to do it. So you either find your fire or possibly fail. You know what I mean? Like it's because there really is no option to not give yourself over to the situation. Is that the day of graduation?
That cannot be the only making $14 an hour.
Amen. All right, we need to get back. Okay. Because of the adverse effects of the aminoglycosides, it is important to teach the patient to restrict fluids and eat 6 small meals a day. Absolutely not. First of all, the only time I'm ever telling you to restrict fluids is when you're on a fluid restriction. Okay? We don't tell people that. And this drug is nephrotoxic. We need water to flush it out. Support healthy kidneys. Okay? So try to drink a lot of fluids and to maintain nutrition. It is very important, even though nausea, vomiting, and diarrhea may occur. Okay. Before we move on to the carbapenems, on page 107 is the nursing considerations for patients receiving aminoglycosides. And it has all the very important things in it. What page you said was, I'm sorry. 107. Nursing considerations for patients receiving aminoglycosides. Talks all about the culture and sensitivity, the CNS effects, the ototoxicity, the nephrotoxicity, the bone marrow suppression. Okay. And it even has a little teeny box at the bottom of the page that says key points. 107. You know, it's fun. It's funny. Like people are they're like listening, and then I say things, and they're like, "Wait a second, what page? That was important. Wait a second. Wait, hold on.
What number did you say?
Wait a tick." Page 107. Okay, carbapenems. This is our next. This is a broad spectrum antibiotic. It's effective against gram-positive and gram-negative. You see, broad spectrum includes both gram-positive and gram-negative, making it broad. So both classifications, okay?
Do all broad spectrum
cover both gram-positive and gram-negative. Broad spectrum cover both gram-positive and gram-negative, unless they are resistant. Okay. So all of these drugs end in penem. Carbapenems end in penem. Your most popular is going to be ertapenem, meropenem. Really, those two. Those two are your most common. Okay. Ertapenem and meropenem. The meropenem is definitely becoming more popular in the last couple of years. The broad spectrum antibiotics, they go through phases. One becomes really popular, and then 5 years later, there's another one that's really popular, and then they just kind of ebb and flow. And it also changes per facility. You'll notice, like, if you ever travel or if you go, if you teach clinical at like multiple facilities, that's how I learned that it's facility-based. Physicians at a facility might really like Mirum, and then another facility like St. E's, we gave Zosyn like it was Skittles. Okay, so
is it sometimes like insurance covered too?
No, we're not allowed to make decisions on insurance coverage. Now, it can be considered if it's like an insanely expensive drug that is not worth like the hardship to the patient. Like on an antibiotic that costs $3 million, if I have an antibiotic that costs $10 million or $10 that works for what you have. Right. That's just ethics, right?
I have a question.
Yeah.
The suffix for this one, is it him? Or is it just like the
It's pen to pen.
Okay, just want to make sure.
Yeah. So carbapenems are bactericidal. They kill by inhibiting cell membrane synthesis, which leads to their death.
What is that? I forget what that means.
Cell membrane synthesis, the way that the cell membrane is made. So synthesis is the way it's made. So this is for serious infections that are caused by susceptible bacteria. So any susceptible bacteria that is sensitive to carbapenems. Treatment of serious intra-abdominal, urinary tract, skin and skin structure, bone and joint, and gynecological infections. Do I need you to know what specifically they treat? Not necessarily. We are not prescribers. We are not prescribing any drugs. Okay? So unless I specifically tell you that I want you to know that it treats XYZ, like with vancomycin, it treats C. diff. Only oral vancomycin treats C. diff, right? That's something I need you to know. With this, I don't need you to list me off that it does intra-abdominal, urinary tract, skin, and blah, blah, blah. Okay? I don't need you to know that. When you go for your NP, you'll have to know. Pharmacokinetics. This is rapidly absorbed if given IM, and it reaches peak level at the end of the infusion if given IV. That reminds me, do you know what a peak and trough is?
The peak is the highest.
The peak is the highest.
The trough is the therapeutic level, right?
The trough is the lowest.
Oh,
What?
the lowest.
Kind of. Yes, kind of therapeutic. Yes. In a way, yes. So the peak, if you are giving a medication IV, the peak is at the end of the infusion. Okay. The highest amount of concentration of the drug when it peaks in the blood is at the end of the infusion. The trough is, yeah, no, she's right, is, yes, it's the lowest, it's the most stable, and it's the most therapeutic level. So if I have vancomycin due at 9 p.m. and I need a trough so that pharmacy can give me the appropriate dosage for my patient to be therapeutic, I need my trough to be drawn an hour before it's due. Okay? Because I need to know what that number is before I give my medication. Because what if the vancomycin level is too high? I'm either not giving it, or pharmacy is going to adjust the dose significantly lower. What if my patient's not therapeutic? Then pharmacy is going to adjust my dose to give a higher dosage. Okay? Peak and trough levels are very important. Okay? Widely distributed throughout the body, it is able to cross the placenta and enter human milk. It is excreted unchanged in the urine, so we are going to assume it's nephrotoxic. Average half-life is 1 to 4 hours, which means this is dosed often. Often. So contraindications, Apparently, the only contraindication is an allergy. Use caution for patients that are pregnant or lactating, and you want to test renal function regularly. So that means what lab are we running daily?
Would that be the creatinine clearance?
Not really the clearance, just the creatinine.
Just creatinine.
So what test is the creatinine a part of? And a CMP and a BMP. A BMP is a basic metabolic panel, and a CMP is a comprehensive metabolic panel. So the CMP is going to give more information than a BMP.
Basic and what was it?
Comprehensive.
Probably I do.
Adverse effects include GI tract effects, specifically C. diff.
This can give you C. diff.
Yes, C. diff is caused by killing the healthy bacteria in the gut. Because antibiotics don't just kill bad things, it kills good and bad things. And we have good gut bacteria called normal flora, which is what we also have in the vagina, we have in our mouth. Okay. And that normal bacteria, that normal flora protects us. So if the antibiotic is killing all of your good, normal gut bacteria, is how we get C. diff. CNS effects. You're going to see CNS effects a lot. Most of the time, it's just going to mean headache, dizziness. The zebras are going to be like the ototoxicity with cranial nerve 8 and gentamicin, right? That's your zebra. With this one, it doesn't really have, any antibiotic, especially a heavy hitter, can cause C. diff. A lot of antibiotics can cause C. diff. It's always a potential complication of a lot of antibiotics.
Is it common?
Is C. diff common?
No, is it common to get the C. diff from those antibiotics?
That's the only way you get well, yes. The only way that you can acquire C. diff without transmission from another person is from antibiotics. You can transmit C. diff from person to person.
Yeah.
If you do not use proper PPE and hand washing.
Okay.
But C. diff technically is caused by antibiotics killing good gut bacteria.
Can I ask you something?
Yeah.
Topic?
Off topic?
Kind of on topic, but
on topic.
Long-term care people have these caution lip, right? But they're still out in the hallway. Why are we not?
They're still what?
They're like they have cautions and stuff outside their room, but they're out in the hallway
To be looking
Maybe
at contact.
I don't understand how that's possible.
So do you mean for like VRE and like CRE, like in the urine, like
It's not just
C. diff?
So technically, I'm gonna give you the short of it. Technically, they should be contact isolation in their room. However, that is their home. We cannot hold them there. So if they want to leave their room, we have to keep everybody as safe as possible. Don't let them touch on people, but that's their home. We cannot kidnap them to their room. That's the
See, like that doesn't fly in acute care setting.
yeah.
Like that would never happen.
Hospitals, you would be stuck in your room. Long-term care, it's different. They have rights to do
Which
it.
sucks.
Yes.
But anyway,
But yeah,
so consider alternative if patient is taking valproic acid. What is valproic acid for? Seizures. So combination of these drugs can cause serum valproic acid levels to fall and increase the risk of seizures. Have you ever been taught about a seizure threshold? I'm going to take that as a... Okay. So everyone, me, you, every single one of you have a seizure threshold. Okay. I've never had a seizure. Mine's up here. Okay. If you have a seizure disorder, okay, that means my threshold is up here, but yours is down here.
So you're more susceptible.
So what can cause you to have a seizure would never cause me to have a seizure because my threshold is all the way up here. What anti-seizure medications do is they raise your threshold. Okay. So if we take drugs that interact with your seizure threshold by decreasing it, then you will be more susceptible to seizure activity. Okay.
Good question.
Yeah.
C. diff, would that be considered a super infection and a GI tract infection?
C. diff can absolutely be characterized as a super infection. To become a super infection, it has to be spread among like multiple patients and not susceptible to a lot of antibiotics. That's what causes it to be we also call them super bugs.
Okay.
Uh-huh. Okay, before we move on to cephalosporins, the nursing considerations for carbapenems is on page 109. It talks about history of seizures.
What about family history of seizures? Does that have anything to do with taking that medicine?
No, family history of seizures and having actual seizure activity is different. Impaired comfort related to GI or CNS effects, superinfection risk related to loss of normal flora. Make sure you're looking at these nursing considerations. What's happening? What was it? If you tell me, I can tell you.
Yeah.
Aminoglycosides? Ototoxicity? Renal function? Bone marrow suppression. Cranial nerve 8. Was that it? Cranial nerve 8. It affects your hearing. Okay, moving on. Cephalosporins. Who did I tell you we were related to? Penicillins. Cephalosporin is a cousin to penicillin. Okay? It is similar to the penicillin in structure and activity. We have 4 generations of cephalosporins. Okay? This is kind of important, the generations. Okay? So in your first generation, the most common is going to be cefazolin and cephalexin. Those are your most common first gen cephalosporins. The second gen is cefoxitin. The third one, cefoxitin. The third generation is going to be definitely Ceftamir, is a huge one. The first one. Yeah, Ceftamir. But Ceftriaxone. And also ceftriaxone, which is rocephin.
No, I'm outside, sir. You see? The second one we have.
Cefoxitin.
Yeah.
So the first one is going to be cefazolin and cephalexin. Those are your two common ones in the first gen. Second gen is your cefoxitin, is your most common. Third is your ceftonir and your ceftriaxone. And fourth is your cefepime.
So this drug class has a prefix, not a suffix. Is that right?
Yeah. Yeah, pretty much. She said this drug class has a prefix, not a suffix.
The most common would be like the CEF, right?
The CEF would be the variable, yeah. Well, not the variable, the constant.
So is each generation, is that like a level of the intensity of that drug? Or
No,
just
each generation works just a little bit differently. Okay. So the first generation work. This is all on page 110. First generation cephalosporins are largely effective against the same gram-positive bacteria that are infected by penicillin G. Second generation cephalosporins are effective against the previously mentioned strains as well as H. influenza. Sorry.
do we need to
I feel like I am going to say something that's important. And I will tell you when I do. The second generation cephalosporins are less effective against some gram-positive bacteria. Third generation are effective against all of the previously mentioned strains, have less activity against gram-positive bacteria, but are more active against gram-negative. Okay, so it seems like the more we go down, the more broad we get. Okay, so first generation is only gram-positive. Then the second generation is gram-positive, but then covers a couple more bacteria. And then the third generation is all of the ones that 1 and 2 cover, plus a couple more. And then the fourth generation is gram-negative and gram-positive. It says, in general, as the generation number increases, the medication is more likely to reach cerebrospinal fluid, be less susceptible to beta-lactamase destruction, and more effective against gram-negative organisms. So they get more broad by the fourth generation. Okay. So these drugs are both bactericidal and bacteriostatic. So they kill, and what is bacteriostatic? They make the drugs. Inhibits the growth. Inhibits the growth.
Slows the growth down.
So it does both. So not only does it interfere with the cell wall building, it also stops the growth of the bacteria. So primarily excreted, unchanged in the urine. What does that mean? Nephrotoxic. Eliminated primarily by the liver. It's the first time we've seen this. What does that mean? Probably hepatotoxic. Crosses the placenta and enters the human milk. So I want to be extremely cautious in patients that have hepatic or renal impairment. Also, this is very important. On page 112 at the bottom, where it says contraindications and cautions. Use caution when a cephalosporin is prescribed in patients with known allergies to other generations of cephalosporins or penicillin. I told you they're related. They're cousins. If I am allergic to penicillin, I am at risk. It's not a for sure. I am at risk of an allergy to a cephalosporin. That is very important to know. Is GI, and that includes vomiting, diarrhea.
Hey, Jess.
Yeah.
I'm not sure if it's just me. I really hear you, dear.
No, it sounds like she's underwater.
Oh no. Has it been long? Please
It's
tell
been
me no.
Just gotta be closer to the computer.
How long has it been happening for?
not very long, but it's happened a couple times off and on. For me at least.
I was at home when I was watching you. Every time we would walk away from the computer, you would get more.
I need to get one of those mics. I should totally get a mic.
Yeah.
Because I like to walk around. Can you hear me better or should I connect to my hotspot? Better?
I mean,
Okay.
it's okay right now, but it does cut out here and there.
I'll connect. No worries.
Thank you.
I'll connect. You're welcome. I should totally get a mic.
You should.
I never thought of it until right this very moment.
I have little Bluetooth, so you could just clear in my shirt.
Can you hear me?
Yes, ma'am.
Yes. All right. Okay, so common adverse effects of cephalosporins involve GI tract, nausea, vomiting, diarrhea, anorexia, abdominal pain, flatulence. She said I sound like a Pepto-Bismol commercial. C. diff. CNS includes headache, dizziness, lethargy, paresthesia, which is that tingling in your fingers and arms. Nephrotoxicity. When these drugs are given IV, it can increase the risk of phlebitis, inflammation of the vein. So we always, first of all, you need to be assessing your IV site at least every 4 hours, at least. Making sure you're not seeing signs of phlebitis. Increased nephrotoxicity risk with concurrent administration with aminoglycosides. So am I giving gentamicin with cefepime if my patient has decreased renal function? Absolutely not. Absolutely not. Okay. And increased bleeding with warfarin, which means it increases the effects of the anticoagulant, which puts our patient at risk for bleeding. Okay. To add, it does say frequently monitor patients receiving this combination and evaluate BUN and creatinine if you are giving aminoglycosides and cephalosporins together. Then BUN and creatinine. Okay, you're writing their patient receiving Cefaclor. What would be an appropriate nursing conclusion for this patient? Let's be. B, impaired comfort related to GI or CNS effects. Nursing conclusions related to the drug therapy might include impaired comfort related to GI or CNS effects of the drug, a superinfection risk, and knowledge deficit regarding drug therapy. So with this question, it's asking about the nursing process. What part of the nursing process are we thinking about? So planning includes that the patient will have an understanding of the drug therapy. Performing culture and sensitivity tests and monitoring renal function are assessment and intervention, which is why the other ones are wrong. Even though they're not wrong, they're just part of a different part of the nursing process. I always hated questions like this.
So I'm like, I'm gonna pick C. I said between B and C for sure. I said B.
So let's go back to the question. You're writing a plan of care. So you're in the you're writing a plan of care for a patient receiving Cefaclor. What would be an appropriate nursing conclusion for this patient? So what are you going to expect?
So to start off a question like this, you're gonna cancel out the ABCs, Maslow's, and you're gonna think about the nursing process.
Yes.
See what I'm saying?
Absolutely, yes. She's saying with a question like this, you wouldn't think about ABCs, you wouldn't think about Maslow's, you wouldn't think about these things because this question is specifically asking you about the nursing process.
What's that?
Add time.
So it's like when we give this medication, we know it's gonna cost them adverse, but they try to comfort them through the.
Like, what do you expect? What is your expected outcome?
So you're gonna have.
So basically.
Okay, so I can see why C wasn't.
So is C correct? Absolutely, C is correct because it's nephrotoxic. But C is part of evaluating.
Yeah.
I guess what's confusing me is when it says nursing conclusion.
Yeah, I don't like the word conclusion.
Yeah.
I agree. I don't like the way that it was written because to me, this is more of a nursing diagnosis.
Yeah, that's what I think by B.
And maybe I think they're trying to get away from the word diagnosis because technically nurses cannot diagnose. And I think they're trying to get away from using that word, and maybe they're using conclusion instead of diagnosis. I don't know. I didn't get the memo. But that makes sense to me, because when you're writing a plan of care, you're coming up with nursing diagnoses that include so assessment. We're not talking about assessment. Diagnosis, if we're writing a plan of care, then we need to figure out our nursing diagnoses.
Hey, Jess, I think it's way worse with your hotspot.
Oh, wow. All right.
It's way worse.
Can you hear me? Did it connect? Can you hear me?
Yeah.
Yeah. Okay, so we were talking about the nursing process, and it wouldn't be having an understanding of the drug therapy, because that's in your evaluation, your education. Impaired drug comfort would be your nursing diagnoses. Monitoring renal function would be your assessment and evaluation. And then performing culture and sensitivity would be for, I mean, to me, that would be for planning, but it's not part of your plan of care. Oh, intervention. So I don't like to use these types of questions because I hate them. Because I've always had issues with them, with the nursing process questions. Fluoroquinolones. There is very important things for you to know about fluoroquinolones. Your most common fluoroquinolones is going to be ciprofloxacin, levofloxacin, moxifloxacin, and ofloxacin is becoming a little bit more popular. The last two that I said are not very popular, but they're becoming a little bit more and more. Does anybody need me to repeat them? They're all except the second one.
Yes, will you repeat that, please?
Yes. Everything but the second one. Ciprofloxacin, levofloxacin, moxifloxacin, and ofloxacin. I've seen it a handful of times, not a lot. Only a very small handful. These drugs are bactericidal. They interfere with the action of the DNA, leading to death. They are broad spectrum, so they're gram-positive and gram-negative. And can also be used in the treatment of anthrax. Do you guys remember anthrax? Mm-hmm. How old are you? Yeah. And you don't remember anthrax?
He was probably in Florida when it
We were in Florida. Yeah.
I'm almost 27 and I don't remember, so.
27 is more understandable, I guess. I don't know. I'm 34. Anthrax. No. Anthrax is a really, really, really scary thing. They were sending anthrax in the mail, and people would open their mail and they would die.
Oh, wait, now I remember. Yeah.
Yeah, it was like super scary. And then literally nobody would open their mail. And then there was a threat that it was inside Tylenol. So then there was a huge boycott against Tylenol because people were scared it was going to kill them.
I feel like I remember this situation, but I don't remember nothing.
Oh, girl, anthrax. That was a time.
Didn't that start like after 9/11? Ain't
I
that
don't
when
know.
it
It
started?
probably did start after. I don't know. I'd have to look it up.
It was after 9/11.
That's what I thought.
Yeah, wasn't it like within the last like 10 years or something?
She said I missed those days. 9/11 was 25 years ago, friends.
I meant anthrax was like in the past like 10 years.
My children were babies.
No, there was something that happened with anthrax in the last 10 years, but I'm talking about like the big one, the big anthrax scare. Like, literally people were scared to open their mail because people were dying. So it was crazy.
What's that?
Yes.
The only thing I've ever had in the world was AIDS. But yeah, I did.
Swine flu. Okay, sorry. Back to the fluoroquinolones. Okay, because we only have 30 more minutes. So this is absorbed from the GI tract, which means we can take it orally. Metabolized in the liver, which means it's hepatotoxic. Excreted in the urine and feces, which means nephrotoxic and can cause C. diff. And basically everything crosses the poor placenta and enters the human milk because everyone hates us when we're pregnant. Okay. It is not, so not even caution, it is not recommended for use in pregnancy or lactating unless it is specifically indicated. So it has to be very, very specific.
And that's going to be like a risk versus benefits type situation, right?
Correct. So most infections in patients who are pregnant should be treated with an alternative class of antibiotics. And that's all it says. It doesn't say if it gives your baby 3 eyeballs.
I actually think it does something with the
It does not fetus deletus. Because there will be some we come across that are fetus deletus. And you will have to know those.
Does it have to do with like grade?
I don't know.
I had pneumonia and I was pregnant. And I usually take blood because unfortunately I get it every year. And they would not give it, to me.
It's not worth the risk
to developing cartilage.
So the very biggest, hold on. Renal dysfunction and association with damage to developing cartilage, which brings us to our very, very biggest zebra. Our very, very biggest zebra. Tendon rupture. The zebras? It's still on there.
Big box with starting.
The pretty ones that you made.
They're still on Brightspace in week 1. Yeah, that zebra one is tendon rupture. Tendinitis leading to tendon rupture is your very biggest gigantic zebra. Peripheral neuropathy, like with diabetes, where you can't feel things in your feet and your fingers. Prolonged QT interval. We talked about that a little bit with cardiac. When we looked at the EKG strip, the QT prolongation can cause weakness, syncope, fatigue. So when you have a drug that causes prolonged QT interval, you don't want to put them on another drug that also causes prolonged QT interval. So if you have a patient that's prescribed ondansetron, gisofran, and ciprofloxacin, they are going to be at an increased risk for QT prolongation. It can be, it can have a decreased effect if we take things like iron salts, sucralfate, which is caraphate, multivitamins, calcium, magnesium, antacids, because those are all bases. They all neutralize. So they can decrease the effectiveness or absorption. If you have to take any of those drugs, they need to be at least 4 hours apart. It says that specifically on page 115. I know, I hate online books. I hate them. Caused by QT prolongation is an arrhythmia called torsades de pointe. Tis French, was found by a Frenchman, which is why it sounds French. Okay. Torsades looks like a sound wave. So it's a jagged rhythm, and it's small and then it gets big, and then it's small and then it gets big, and then it's small and then it gets big. Okay. It's a ventricular rhythm, arrhythmia, that we'll talk about in a couple months. But it's important to know that prolonged QT can cause torsades, which is not sustainable and can lead to cardiac death.
SADE.
Torsades, TOURSADES. Torsades de pointe. Cardiac death. Torsades is a type of arrhythmia that can be caused by QT prolongation and can lead to cardiac death. So if you have a bunch of drugs that cause QT prolongation and you put them inside of a human, it could be bad, is my point. So some of these drugs are listed on page 115 and include amiodarone, sotalol, erythromycin, tricyclic antidepressants, phenothiazines, and like I said, ondansetron. That's all on page 115. They can increase the anticoagulation of warfarin. So an INR needs to be monitored closely.
You said it increases, sorry.
The anticoagulation of warfarin. In my opinion, I love cardiac, so cardiac's not the hardest for me. Endocrine, so in my rank, cardiac is third, endocrine is second, and antibiotics are first for me because there's just so many zebras. I hate. But to me, it's the hardest one to grasp. What is a contraindication to receiving a fluoroquinolone? This is easy.
Cipro.
Allergy to Cipro, duh. Okay, so I think it would be very important for you to look at the nursing considerations for patients receiving fluoroquinolones that starts on page 115 and continues on page 116 and also has a box of key points for fluoroquinolones on page 116.
I need to go get my protein bar before. I'm right afterwards. We don't have enough time to take like right. You know, these are shortcuts for all people.
Do what?
This is the shortcuts for all people. Just I'm pretty sure
I think for the week.
yeah.
He said there's still more printing too. Maybe I think she said like 14, yeah, we just 14, 15, 16 or something. So this week we've got 8 through 14, and I think she only printed 13. Next week is 15, 16, 17, 18, 56, 57, 58, 59, and 60.
Yeah. 15 to 18.
I just know about this. So if you go to learn and it show flashcards and it show cardiovascular system, endocrine system, and it got flashcards for each one and it prompted you through the whole thing.
Yeah.
Just learn that.
Okay.
It's the cookie dough built protein. Candace was just saying that ATI has a whole thing of pharmacy flashcards. And that they're very helpful. All right. Penicillins. This was the first antibiotic ever introduced for clinical use. We have natural penicillins, and then we have amino penicillins. Amino meaning protein, so they're protein based. We have penicillin G, penicillin V. We got amoxicillin, ampicillin, and then combination. Penicillins love to be in combination with other things, with other drugs. Your most common, penicillin G is common in OB, amoxicillin and ampicillin. And then your combination meds are going to be popular, like your augmentin. Another popular combination is called Unison. That's an IV antibiotic. It's ampicillin with sulbactam. These are bactericidal. They treat streptococcal, pneumococcal, and staphylococcal infection. They're rapidly absorbed from the GI tract, excreted unchanged in the urine, so nephrotoxic, and enter human milk. Use caution in patients with renal disease. Lower doses are necessary because excretion is reduced. Use in patients who are pregnant or lactating should be limited to situations in which the patient clearly would benefit from the drug, because diarrhea and superinfections in the infant may occur. These drugs specifically should be taken on an empty stomach. They are sensitive to gastric acid levels in the stomach and should be taken on an empty stomach to ensure adequate absorption.
And this is for all penicillins?
Yes.
Okay, thank you.
Did we know why they would be taken on empty stomach or just know that these just but then do we to know that or just know that these are the ones that need to be taken on the stomach? Because they're gonna be a situation that we need to understand the mechanism of why.
I mean, I don't know. I don't remember the questions on the final right in this very moment. I just know, the gist of it.
Gotcha.
It's been 3 months. And I have to change it. Adverse effects. Oh, drug-to-drug interactions with parenteral aminoglycosides. Parenteral means around the intestines, which means not oral. So IV, IM, ointment, drops. What else? A drug-to-drug interaction. It says, when the parenteral forms of penicillin and penicillinase resistant drugs are administered in combination with any of the parenteral aminoglycosides, inactivation of the aminoglycoside occurs. This combination should be avoided. So penicillins are like an antagonist to aminoglycosides. So they should not ever be given together.
Because they cancel each other out.
Well, the one cancels the other. The penicillin cancels out the aminoglycoside. A little bit more on penicillin. We have adverse effects. Ugh, this is gross. Glossitis, inflammation of the tongue. A furry, F-U-R-R-Y, furry tongue. These effects are primarily related to the loss of bacteria from the normal flora and the subsequent opportunistic infections that occur. What is an opportunistic infection? We're going to talk about it on Thursday, but does anybody know?
Primary diagnosis that you are more susceptible to certain bacteria's infections only because you already have another diagnosis.
Kind of. So these are infections that are not common in people that have a normal functioning immune system. So specifically, when AIDS first became a thing, there was very specific infections that were occurring that we don't see. We never saw these infections unless they were in severely immune compromised patients. Okay. So Kaposi sarcoma is very specific to the AIDS diagnosis. It is called an opportunistic infection. When you have oral candidiasis, so a yeast infection in your mouth, that is like, I'm not talking like a little bit, I'm talking level like 1 million. that is an opportunistic infection. Okay. I feel like that's it.
So if you have an opportunistic infection, does that mean that there's a bigger problem?
Oh, yes, absolutely. If you get diagnosed with an opportunistic infection, they are going to figure out why you are so immune compromised. That's what was killing everybody with AIDS. And they didn't know it was AIDS. They were just seeing these patients getting sicker and sicker and sicker, and they couldn't understand why. So the whole point of not having HIV progress to AIDS is to have enough immunity and immune response to not have those opportunistic infections. Sulfonamides. Ooh, also, there's a box on page 121, box 9.5. It says focus on patient and family teaching. This drug should be taken on an empty stomach with a full 8-ounce glass of water, 1 hour before meals or 2 to 3 hours after meals. Do not use fruit juice, soft drinks, or milk to take your drug, because these foods may interfere with its effectiveness.
What page again?
121, box 9.5. Okay. This will be our last one. Sulfonamides. These are drugs that inhibit folic acid. Folic acid is essential to our cells. So bacteria also need, like if it's a bacteria that needs folic acid to survive, sulfonamides can inhibit that synthesis, so it cannot survive. Okay. Your most common is the last one, the combination, the trimethoprim, sulfamethoxazole. That is Bactrim. That's your most common. So these are bacteriostatic. They treat gram-positive and gram-negative. And they're really good for UTIs and I don't know what it means by trachoma. Oh, these drugs are used to treat trachoma, a leading cause of blindness from C. trachomatis infection. Oh my. Scary. Oh, we don't see it because it happens in developing countries. Trachoma on page 122. Teratogenic, what does that mean? Fetus deletus. That means I don't like your baby and I'm going to eject it.
Which word? What'd you say? What means what? What means that? Oh, teratogenic. Never mind.
So, but for real though, it can cause miscarriage or bad things to happen to your fetus, but specifically it can cause serious birth defects. and should never be used during pregnancy. So it can physically alter your baby or cause fetal death.
Is it because it's totally accident?
It says kernicterus. I have no idea what that is. Bless you. I gotta look that up. Kernicterus.
You're gonna teach our little bit sweetest stuff.
Sweetest deletus, yeah. Absorbed from the GI tract, which means it's probably going to put us at risk for C. diff. Metabolized in the liver, hepatotoxic. Excreted in the urine, probably nephrotoxic. Ding. Known allergy not only to sulfonamides, but also to thiazides and loop diuretics. Interesting. It also says under contraindications and cautions, these should be used with caution in patients with renal disease or a history of kidney stones because of the possibility of development of kidney stones, especially if not well hydrated. They should be used with caution in older adults because of the increased incidence of thrombocytopenia, hyperkalemia, and folate deficiency.
Can you say that again, please?
It is on page 122.
Thank you.
It can increase the incidence of thrombocytopenia, hyperkalemia, and folate deficiency. So adverse effects, your normal GI stuff, the death of normal bacteria leading to C. diff. Renal effects are related to the filtration in the glomerulus, which is where the kidney stones come in. Can cause hematuria, hyperkalemia, and proteinuria, which means protein in the urine. Protein's not supposed to go in the urine. No. I'm reading all this off page 122. Bone marrow suppression. And surprisingly, this is the first time we've seen this because I feel like when I was in nursing school, I wrote this 100 million times. Stevens-Johnson syndrome.
Mm-hmm.
Oh my God, I feel like I wrote it so many times. Like everything in the world caused Stevens-Johnson syndrome. That's just how it felt. But specifically, sulfonamides can cause Stevens-Johnson syndrome.
That's for everyone or just older adults?
So everyone. It is a rare but severe skin and mucous membrane reaction. Super terrible. Like the skin literally like sloughs off. Oh, it's 229. Important stuff about sulfonamides. Increasing your potassium. So medications that increase hyperkalemia, you wouldn't want to take multiple drugs. So you wouldn't want to take spironolactone and lisinopril and a sulfonamide all at the same time, increasing your risk for hyperkalemia. You don't want to take these with cyclosporines. because it will kill your kidneys. Okay. Questions?
How many more lecture days do we got? Thursday and Tuesday, right?
Yeah.
And then you said Monday we're going to review for 1 and 2? Or did I
Monday
get
at
that?
3 o'clock is the exam review. Monday at 7 o'clock is the review for the finals.
Okay. You know how many
Unless,
questions?
unless I get through everything on Thursday, and then I can do the review on Tuesday during class instead, I'll do that. Can't hear? What do you mean you can't hear? Turn your volume up. Just kidding. Just kidding. I'm just kidding.
How many questions you gonna have on the final?
Girl, get out of here. Get out of here with that.
That's a valid question.
Get up out of here. I don't know, at least 70. At least. At least 70.
Oh gosh, I thought you said 17. Thank God.
No, 70. 70. At least 70.
I mean, at least 17 works too. But
That would be terrible.
No,
If
I
there
don't
were
think so.
17
if there's a
You'd
minimum,
probably
then
fail.
Oh my God, they'd be worth so many points. In critical care, I have a case study worth 16 points.
that's crazy.
That's pretty
On
cool.
a test?
I'm actually really proud of it. Yes, it's on an exam. It's a case study that's worth 16 points. It's gonna be great. Huh?
That's disgusting.
Each part of the case study is worth its own points, to be fair. So like you don't have to pass the whole thing. Like you can literally like say the first question you miss one, like it's 15 out of 16. You know what I mean? Like it's not like a one and all thing. Okay.
Were you able to find that email for my
Thank you.
chapter for my Prep U 47 that I sent you?
Oh, yeah.
It wasn't put in yet, so I wasn't sure.
Well, that's because your girl's been busy.
Oh yeah, I know that.
But yeah, you're not the only one that had issues with chapter 47, like specifically chapter 47.
Yeah.
So I'll take care of that
Okay.
eventually.
Yeah, it's fine.
Bree, can you still not hear me? Oh, she's gone. Any other questions, guys, before you leave? Anybody? Okay. Okay. Have a wonderful day.
Thank you.
Hmm?